Hi, I'm Anne O'Neill. I'm one of the founding directors of Healthwatch Brent. My business address is care of Brent Mencap, 379 to 381 High Road, Willesden, Northwest 10 to JR. And yes, the evidence that we've got here is the evidence that we wish you to take into account. And my colleague will introduce himself.
Okay, my name is Ian Niven. I'm the coordinator of Healthwatch Brent. I have the same business address as Anne just gave.
Could I ask you both first to explain, please, by whom your organisation is funded and to whom do you report?
Okay, Healthwatch Brent is actually funded by Brent Council. We a consortium of local voluntary sector organisations in Brent bid for the Healthwatch contract in October 2012. We heard that we've been successful in February 2013. And it was a consortium of organisations that included Brent Mencap, CAB Brent, Age UK Brent, Brent CVS and Elders Voice Brent. All organisations that work with some of the most vulnerable people in Brent, and we felt that we would be able to enable their voices to be heard.
So to whom do you report?
We report to Brent Council, to what was then the Policy and Resources. I'm not quite sure. I think it might be the Partnerships section now after the reorganisations.
Now, we've had witnesses from Healthwatch organisations from Ealing and Central West London, and they both described their relationship to shaping a healthier future as that of a critical friend. Is that a fair description of your organisation, or would you put it differently?
Our relationship with shaping a healthier future was, I think, a lot of the work had been done prior to us being set up, and we were in the throes of sort of setting up in early 2013. So we were aware of what was going on. We tried to translate what we understood was happening in the bulletins and in the information that we sent out to people in Brent and asked them to get involved and give their views. We attended some of the meetings and felt that what was being presented at one level seemed to be sort of sensible, but obviously we're not health professionals, we're not health analysts, we are sort of a group of voluntary sector directors, and our key aim was to try and make sure that people in Brent who are perhaps not all fair with it understood that there were major changes going on, and if they didn't agree with them, it was, we would help them have their voices heard.
I just want to ask you a little bit about that in the consultation process. In front of you, you'll also see a volume marked volume 5. Can I just ask you to turn to page 1747, please? I just want to see if I can invite you to comment on something. This is a document by a GP, Dr. Sahota, who also sits on the GLA. If you look at paragraph 11 at the bottom of it, he talks about the consultation, and what he says is this. Further, the response questionnaire was 15 pages long with 50 questions designed to frustrate and exhaust the respondent. The questions were framed in a way to lead to the conclusion that the proposed A&E closure is based on sound science. The response document was not designed to get genuine feedback from the local population. Further, one NHS trust was set to compete with another. In terms of the design of the consultation document, do you share Dr. Hota's view, or do you have a different take on it?
I think generally one of the positions that Healthwatch Brent has taken in all the meetings that we've attended is most of the documents that are produced by the NHS and at times the council are written in very sort of highfalutin language. They use a lot of acronyms, and I don't think anybody would say that people feel that there is a real genuine will to consult, that actually they go through the motions of saying we are consulting, we are engaging, but it's often done at very short notice. Sometimes they'll give you 2 weeks and want you to kind of comment on or get feedback on something that actually would take a good sort of 2 months to really explain to people let them go away and think about it, and then actually come back with a sort of an informed response. So I think his points are well made.
And you talk as well in your document about being overwhelmed by large volumes of documentation. Now, given that you are people who are tasked, employed to have that very job, to deal with that, what, in reality, do you think are the chances of lay members of the public being able to digest the necessary information to make sense of this?
Well, you've got lay members here who have digested it really, really well, I think, but I think they're kind of extra special. I think the average person in the street, they just want to be able to go to their GP, or they want to be able to turn up at the hospital, or they want to come here to the council, and they just want to have a decent service. And they trust the professionals to actually deliver that for them. I think there are things that you can consult meaningfully on with residents if it's done in small chunks and in accessible language. But I don't think most members of the public would understand it. And when you think that we're not health professionals and we're not council employees, and all of the people that were involved or are involved in Healthwatch, Brent, we struggle to make sense of the complexity of the meetings that exist and the governance, and how the federation, for example, there are 3 boroughs that are in one federation, then there's another federation that's got 8 boroughs in, and you've got these weird and wonderful committee structures, and it's really, really difficult to get your head around.
So are you saying that in reality, for you and for people who are participants in this, there's a difficulty in being able to, first of all, read and digest the documents properly, and secondly, to actually engage fully in the meetings that you attend?
When I go to the CCG's quality, I even get confused in the name of the meeting, but it's the quality, research, risk and something else meeting. I get sent a bundle of papers that's about that thick, that contains different reports. It contains the performance reports from the different hospital trusts. It contains how the CCG's doing. It can take me 2 hours to work my way through it. And generally I'm able to comment, but it took me probably about 8 months of going to that meeting to actually feel I could say much more than, you need to make this easier to understand, there needs to be easier summaries. And that's just one meeting. So I think if you were to attend all the meetings that we were invited to attend, it would have been a full-time job for somebody to actually have gone to those meetings, understood it, and commented, and that's not allowing any time to actually find out what other people think. I mean, certainly the colleagues over there would often give us their views on particular papers or particular issues, but it's impossible, I think.
Do you think that there may be a risk, or there may have been a risk, that on occasions people have signed off on matters that they didn't fully grasp?
What people were you thinking of?
Participants at committees asked to endorse a decision by a committee or to lend their name to it. Is there a possibility, because of the plethora of documents, the confusion, the difficulty of digesting that you've just described, that there may have been occasions where people have signed off on documents and said basically yes, okay to stuff, without really properly understanding what was being asked for?
I don't think we've any evidence.
I think that's probably likely. I mean, again, when I think of the risk committee that I attend, it's a 2-hour meeting, and you're going through anything up to about 18 quite important documents, and they generally, do only take 2 hours. I think they are just whizzing through really, really quickly. So that's the thing. So I imagine there are other meetings where people are attending and possibly not interrogating what's in front of them, because they trust the officers that are presenting the evidence to have done, the sort of investigation.
So in terms of your organisation's ability, and I use this term loosely, to scrutinise rather than specifically to scrutinise what's going on, how does that impact on your ability to do that, to fulfil that role?
We weren't set up to scrutinise. I think that's the Healthwatch is not a Health Partnerships Overview and Scrutiny Committee. Its role is much wider than that, and my colleague can kind of explain it in a bit more detail, but it's about being a champion for the consumer, but it's not just about health, it's also about social care. But it's also about having links with Healthwatch England, it's also liaising with the CQC, it's about enabling people to know where they can complain and have their voices heard. So scrutinising these sorts of things is only one part of the work that Healthwatches do.
But as far as that part is concerned...
Yeah, can I comment?
Please. You need to sort of one off.
So I'm operational and so I'm more strategic in this. I've just very recently, I'm waiting for guidance from Healthwatch England in terms of local health watchers' role and scrutiny and to what degree. And it's one of the many areas that needs to be a bit more clarified. Certainly, there could be a choice within the local health watch to do nothing but scrutinise something as complex as this and absolutely nothing else with the resources available, or fulfil its wider function of actually getting patients' voices in as wide a range as possible and representing, whatever those issues may be. It would certainly be impossible in this particular complex case like this. And yet, there is some expectation around a local health watch scrutinising. So I think that needs to be clarified, and we need to be quite realistic about to what degree, where are the limits of that given the resources available to a local health watch.
So are you saying there's perhaps a slight confusion of your role as to whether or not you're there to scrutinise what's going on, or whether you're there to provide a conduit of information from the CCGs and staff to the public?
Yes, I'm just clarifying that. I think some of that has been clarified over the last few years, but I've felt the need to go back to Healthwatch England and ask, to clarify that a bit further. So I think some language is used in different documents, and the word scrutiny role we'll find in various Healthwatch guidance. So I'm seeking clarity of just exactly what is meant by that. And the other thing I was saying, which I think refers to your first question, in terms of capacity, and for something as complex as this, it's not something that a local health watch, would have been able to do unless that's all it devoted its attention to, so complex and time-consuming. So we couldn't scrutinise this, the whole shaping a healthier future, and fulfil other expectations and roles and functions.
Can I just ask you a couple of specific matters? On page 710, 711, you talk about the staff turnover at the CCG.
Yeah.
And I want to ask you about that. First of all, what was the problem? What seemed to be the problem?
I'm getting answers, so that the people who write our bulletin would often be seeking answers to questions that patients, had raised, or issues that had been raised with us. So it was actually trying to get straightforward answers to things, and that was made difficult by people changing roles within the CCG and other organisations, or the number of interim roles. And we did inquire, what's this, the one that was turned into Freedom Information, I can't remember. Yes, it did. Yes, we just wanted to know who was who to speak to, who would give us an answer on what. And the CCG turned that into a Freedom of Information request, which seemed uncalled for.
Was that when you say they turned it in? Did you make a simple inquiry?
Yes.
And did you ask for Freedom of Information?
No.
Request? Do you know why they turned it into FOI?
No.
What was the response?
We have, there was a list of a paper which is, I haven't included here, though we do have. It was a list of names and roles, and the list here on page 711 were an explanation of the acronyms that were used in that list of roles. The list of roles itself didn't precisely answer our question either. Just added a bit of confusion. It didn't precisely say, you know, this committee, this line of query, this work stream would be answered or dealt with here.
What I wondered about was what you say in the document, and it's at 4G on 710, is this. NHS Commissioner James Lorrigan has left his post. A member has reported that 80% of the commissioners have been laid off. And Healthwatch Brent is trying to find out who the new or remaining commissioners in the Brent CCG are and their area of responsibility. Are you able to comment in any way on why or what seems to be happening for 80% of the commission to suddenly be laid off?
Shall I? I think that after the changes in early 2013, some people stayed on. Some people, I think, who'd been made redundant seemed to come back. It seemed to be a common factor, and actually it's also a bit of a theme with the council after some of the sort of changes that took place, that I think the amount that CCGs can pay in management costs was restricted, and I think they thought it was, you know, they would use interims or agency people for a period of time to continue to be able to sort of commission and work out what it was they actually wanted to do. And you go to meetings, there'd be somebody who was the lead commissioner for children's services, and then at the next meeting they'd be gone and there'd be somebody else. And I think so. I don't think that kind of instability was at all helpful. And we were just trying to, and we would say that in meetings, you know, it's kind of really hard when someone's saying, oh, this, and then you, for example, if I quote an example for Brent Mencat, we had been delivering some work for the CCG. We then had said, well, it's coming to an end, you know, what's going to happen to it? There was an interim person commissioning learning disability services. She said, yeah, no, fine, that's great, we'll come back to you, you know, once I've got it agreed. And I didn't get a response. I went back about 6 weeks later, only to be told nobody knew anything about that, and that person had gone, and I had to start the process again. And I think that is fairly common, which, you know, is really frustrating, but also that the knowledge and experience that people had, you think, well, if there's that turnover and that churn, how can you really deliver on quite major changes? You know, that's certainly a concern for us at Mencat, but I think it's a major concern when you've got such big sort of capital or big changes. Where's the continuity? Is somebody actually seeing this through from beginning to end? And one of our questions was very much about who owns these projects? You know, who's actually going to take forward, whatever it is, who's actually going to take it forward? So I think part of the reason for questioning that was to try and get a feel for what's their strategy in terms of keeping key people.
And were you able to get a satisfactory answer from that?
No, because it probably we may have got a snapshot at that time of who was in post, but I think there has continued to be sort of movement within the CCG.
I just wanted to ask you very, very briefly about your work in Northwood Park Hospital, because you conducted 2 patient surveys. One was in December last year and one was in February. Would it be a fair summary to say that what those surveys revealed was that once people were treated, they were relatively happy with the care, but that the areas of concern were waiting times, lack of efficiency in referrals, lack of information about services, and difficulties about accessing hospitals? Is that a sort of reasonable summary of the findings?
Yes.
And I know, because you refer to this, you asked some specific questions, you sent in some specific questions to the operations manager. I have to forgive me because I should have asked her and I forgot. You asked Tina Benson to respond to your inquiries. Have you had a response?
They were very sluggish, disappointingly. So we do have a meeting with them on Friday of next week, with the management team of the emergency department to discuss that report and get feedback from them. That was as a consequence of me asking them if they needed me to remind them of their statutory duty to respond.
When you have been to that meeting, are you able to please feed back into the Commission
Yes.
the results of that, please?
Absolutely.
Thank you. I'm very grateful. I have no further questions, but if you wait, there may be questions from the Commissioners.
Okay, can I just clarify that the questions you were asking about Tina Benson are the ones on page 717? When you were talking about the response, the lack of one from Tina Benson?
Yes.
717.
Yes, from
Yes,
my...
it is.
And yes.
The results are on. It's 716 and 717. I beg your pardon. I should have given you
Thank you
reference.
very much. Dr. Hurst.
Can you hear me?
Yes.
Again, to have these recurring themes, you are at least active observers of one part of SHAF. Having regard to the words such as confusion, 80% of commissions being laid off, from the small part of this huge project, do you think the systems are in place to push a project like this through? Again, it's limited with what there is.
I mean, it's enormous. I mean, I simply echo other voices I've heard this afternoon in terms of the, the principle and ideas behind this, having some good sound elements to it. It's clearly struggling. We've been unable to do the sort of forensic analysis that the PPG chairs have done. It's a massive project that would need, and it needs to bring people with it. I mean, we're at least not being kept up to date and informed and kept in the loop as to whether it is actually progressing. So we are blind. So in part, answering your question is, we don't know, but that's worrying. So we certainly can't be certain that the resources and the mechanisms are there to make it succeed. I can look at, on a smaller scale, with the whole systems, integrated care and the way that's going about, and again, that contains stuff that everybody wants, a far more holistic approach to patient treatment. That's a meeting at that is in itself quite a massive undertaking and is deeply flawed from the outset. And I'm not quite sure how they expect to proceed with that. And that's only one, a tiny project in comparison to SHAF.
I think also one of the things I think hasn't been taken into account is obviously all this kind of development has been taking place at a time when the council actually, I think, has had to cut quite senior staff who normally probably would have had more time to scrutinise what was going on, and also to be actively involved in developing project plans. And I do think there's also that side of it, that where the CCG might have asked for involvement. I think the people that are having to get involved are probably doing 3 jobs now instead of just 1. And I do think that there was the Health Partnerships and Overview and Scrutiny Committee that existed going back was doing a relatively good job of looking at what was going on. I think that's probably not functioning quite as well, or I don't think it's functioning at all in the same way. So I think that, again, is something that maybe the council need to think about. And I think, lastly, there have been times when Healthwatch Brent's been quite critical of, council involvement at the Health and Wellbeing Board. I think there have been times, certainly early on, when there weren't as many councillors present and there wasn't a substitute system present. So the CCG, to give them their due, would be turning up and wanting to explain things, and there might only be 2 councillors in the room. So I think that the overall effect of cuts and has probably lessened the ability of the council and also officers to really look at things and interrogate, whereas perhaps 3 or 4 years ago they would have had more capacity to do that. And having worked in Brent for quite a long time, I have seen a decline in that. Those people are often referred to as bureaucrats, people think, oh, all they do is sit in offices and push bits of paper around. Actually, what they did was a very important function of actually trying to look at bigger things that impacted on Brent. And I think that, that kind of cutting of those sorts of posts has probably also not helped. And I think, that's been a shame as well.
Back onto this question about the staffing or the role of the commissioners and who's doing it and so on. There's a recent report in survey in Pulse magazine that said that on average only 11% of GPs were involved with their local CCG. And I'm just wondering, among those who are sort of not there on a regular basis, would that include GP members of the executive, or are they regular attenders? And in which case, if a lot of the day-to-day decisions are actually being taken by GPs, who is doing the donkey work behind the scenes? I presume it's the commissioning support unit. Do you see any sign of them?
The commissioning, I can't comment on kind of GP attendance at the CCG board meeting because I don't go to that. Certainly,
public meetings, aren't they?
Yeah, so I think that you probably could pick up the data on sort of whether they're attending or not. In terms of their attendance at this quality risk, I'm sorry, I never can remember the name of it. The clinical leads are often present there. I think only on one occasion one had to sort of participate through a telephone sort of conference call to the meeting. The rest of the GPs, I have no idea. I mean, there's 70 odd practices in Brent. I don't know. We're told that they're all behind, and that they are very committed to making sure that the services that are delivered in Brent meet the sort of needs of the people in Brent. But I wonder, how much they're all struggling like we are with understanding, the impact that they can have on the planning. But
to what extent do you see evidence that some of this documentary material coming from the CCG is actually drafted on their behalf by consultants or by the commissioning support unit outside the CCG itself? I mean, do you get sort of logos on there and extra names and research by or whatever on these documents, or are they simply all branded CCG and that's it?
No, they're all branded CCG. The commissioning support unit, again, when we were first involved, they were still sort of, I think, part of NHS London, so they were watching over the 8 boroughs. And then I think the CCG made a decision that, because they were paying an amount to have that support, and so they wanted to have a more local sort of CSU. So I understand now the CSU are kind of working just for the Harrow, Brents and Hillingdon, because Ealing's no longer part of that federation. And they seem really, really knowledgeable, and they seem to they'll come and say, look, this provider's having a problem with this thing, this is the action plan we've agreed, or they'll look at their quality account and say, we've told them this is not good enough. I get the impression that they're very, very knowledgeable, and they are holding, say, weekly action meetings, say, with Northwick Park, say, over the referral to treatment sort of problem that they had. I don't know if the CCG think they've got enough capacity or not, but I think they're probably restricted by the amount of money that they can spend on management costs. I think there is something somewhere about they can only spend X amount on those sorts of management costs. I think where it has sometimes got confusing is obviously Brent has one approach, Harrow will have another approach, and as colleagues said, different problems, and Hillingdon will have another approach. And this insistence on almost like having a federation approach to things, certainly from the perspective, say, for example, of the Safeguarding Adults Board in Brent, pressure ulcers was a key priority, and there were certain discussions that were happening about the Trust not necessarily reporting that. And there was supposed to going to be a federation-wide approach to when they should be reported and when they shouldn't be reported. And I think that the Brent, for example, the Brent Safeguarding Adults Board said, well, we want this reported, and then but over the federation, this is what we've agreed. So I think there are tensions even on other aspects of things, which I think it must make it difficult for them, I think. Trying to have a 3-borough approach probably makes sense at one level, but it must be frustrating at times because the needs of the 3 boroughs are very different.
Thank you.
I have no questions. Thank you again very much.
Thank you.
Thank you.